Okay, let's dive right into this explainer and decode the incredibly high stakes medical reality of treating thermal burns. When we think of a burn, we usually picture a pretty localized injury, right? Just a painful spot on the skin from grabbing a hot stove or getting too close to a campfire. But the medical reality? It's so much more complex than that. A major thermal injury triggers a massive, system-wide crisis that pushes the very limits of human physiology. Today, we're going to look strictly at the clinical facts and protocols to understand exactly how medical professionals manage this immense trauma, stabilize the patient, and ultimately save lives. So consider this. When the fire's out, is the burn really over? It's natural to assume that once you remove the heat source, the damage just stops. Well, as we'll see from the clinical data, that initial thermal insult is literally just the spark. What follows is this rapid physiological cascade, where tissue damage can actually expand over the next 24 to 48 hours if it isn't meticulously managed. The fire might be out, but the race to save the surrounding tissue has absolutely just begun. Here is our roadmap to guide us through this. We're going to cover 1. Anatomy and burn depth, 2. The zones of thermal injury, 3. Initial care and triage, 4. Relieving pressure through escharotomy, and 5. Specialized burns and TAR. Starting with Section 1, Anatomy and Burn Depth. We really have to establish our baseline first, and that's the skin. The skin isn't just some wrapper for the body. It is a complex, multi-layered organ. It acts as our biological armor, protecting us from lethal infections and massive fluid loss. It regulates our temperature, produces vitamin D, the whole shebang. When this armor is breached, the entire body goes on high alert. Medical professionals actually classify this thermal villain by correlating depth to visible symptoms. It's fascinating how it progresses. A first-degree burn is superficial. It's limited to the outer epidermis, appears red and painful, kind of like your classic sunburn, and usually leaves no scar. But as we move deeper into the dermis, we hit second-degree or partial thickness burns. Here you're going to see blistering and this wet, weeping appearance. Healing takes weeks and might even require skin grafting. Go deeper still to a third-degree, full-thickness burn, and the entire thickness of the skin is just destroyed. The wound looks white, brown, or charred black and takes on a dry, leathery texture that doctors call an eschar. Finally, fourth-degree burns penetrate straight through the skin layers into the subcutaneous fat, muscle, and, unbelievably, even bone. And the physiological impact directly scales with these depths. Let's move on to Section 2, Zones of Thermal Injury. As we dive into the pathophysiology, the tension really escalates because the damage from a burn actually continues to spread beneath the surface. The visual surface of a burn does not immediately reveal the full extent of the cellular damage happening underneath. This brings us to a crucial concept that Dr. Jackson first described way back in 1947. Think of a burn exactly like a giant bullseye of damage. This isn't just some historical trivia either. This dictates modern burn management. Picture a dartboard. The dead center, where the heat made the longest contact, is the zone of coagulation. The cells here have undergone necrosis, which means irreversible death, and they simply cannot be saved. But radiating outward from that center are 2 more zones that absolutely hold the key to the patient's recovery. Let's compare the 2 most critical areas. You have that central zone of coagulation, which is irreversibly lost, but right next to it is the zone of stasis. This tissue is injured, and its blood flow is severely decreased, but under ideal circumstances, it can survive. And that brings us to the ultimate medical goal. The entire reason burn units exist is to prevent that fragile, injured zone of stasis from dying and turning into the dead, central zone of coagulation. If a patient is mismanaged, they suffer what is medically termed burn wound conversion. And this is a terrifying scenario. Imagine a partial thickness injury that could have healed perfectly well on its own, suddenly converting into a full thickness, third-degree burn requiring major surgery over the first couple of days. So why does this happen? The primary culprits are improper fluid resuscitation, meaning the patient didn't get the right amount of IV fluids, or hypothermia, which causes the blood vessels to constrict and literally starves that fragile zone of stasis of the oxygen it desperately needs. Let's see how this builds into a full-blown systemic crisis. A severe thermal injury triggers an intense, whole-body inflammatory reaction. Our capillaries, those tiny blood vessels, suddenly become highly permeable. They literally just start leaking fluid, electrolytes, and proteins directly into the burn wound. And in large burns, this leak happens all over the body, even in tissues that weren't burned at all. This massive fluid shift leads to extreme edema or swelling, which rapidly drops the patient's blood volume and throws them into hypovolemic shock.
That's a life-threatening condition where the heart simply doesn't have enough fluid left to pump. It's exactly why burn care is a frantic race against systemic collapse. Which brings us to Section 3, Initial Care and Triage. Now we transition from the invisible danger of shifting fluids to actionable medical interventions that anyone can apply in those crucial first minutes before even arriving at a burn center. Immediate care requires following exact pre-hospital steps, starting with sensible cooling. Using cool tap water relieves pain and can actually reduce the depth of the injury in those evolving partial thickness burns. But notice the time limit, up to 20 minutes max for smaller burns. Crucially, you must remove clothing and jewelry immediately, because those rings and watches, they are going to turn into dangerous tourniquets once that massive swelling we just talked about begins. Elevating the injured limbs above the heart also fights back against that rapid edema formation.
However, you really have to be careful with extensive cooling on large burns. The clinical data warns us that sending a trauma patient into hypothermia will only extend that irreversible zone of coagulation we discussed earlier. If a patient gets too cold, their blood vessels constrict, tissue dies, and that dreaded burn wound conversion happens. So removing the clothes and keeping the patient warm in a clean, dry sheet absolutely takes precedence over prolonged cooling, especially for large surface area injuries. Section 4. Relieving pressure, specifically through an eschartotomy. Sometimes the body's own swelling becomes a secondary threat, which brings us to a highly dramatic, life-saving surgical intervention. When that massive capillary leak fills the tissue with fluid, it needs somewhere to go. But what happens if the skin can't stretch?
Well, when full-thickness burned tissue turns into a rigid, leathery band that literally strangles the body, what we call a circumferential eschar, an escharotomy acts as the ultimate pressure release valve. The doctor must actually take a surgical device, often an electrocautery tool, and make a deep, longitudinal incision straight through the dead, burned skin. They aren't cutting into the fat, they're just cutting through that tight, leathery shell to let the underlying swollen tissue expand freely. If a patient has a full-thickness, circumferential burn around their trunk, that rigid skin acts exactly like a straitjacket. If a patient is struggling, presenting with rapidly increasing airway pressures and falling oxygen levels, it means their chest simply cannot expand to take in air. The medical team will notice immediate difficulty trying to ventilate the patient. When this happens, a chest eschariotomy is needed immediately to save their life, allowing the chest wall to finally rise and fall again.
It's a very similar story on the limbs. If fluid accumulates under a tight burn eschar, it creates a tourniquet effect, cutting off blood flow entirely. The patient might report progressive numbness, or if they're sedated, the medical team will detect weaker and weaker pulse signals using a Doppler. The fingers or toes will become dangerously cool. To save the limb from ischemia, which is tissue death from lack of oxygen, the surgeon must cut through that dead eschar to restore circulation. It's super important to distinguish between treating a tight burn on the surface and treating compartment syndrome deep inside the muscle. An escharotomy simply cuts through the dead outer surface layer of burned skin. But compartment syndrome features swelling deep inside the muscles investing fascia, often due to high-voltage electrical injuries or severe crush injuries. That requires a much deeper, far more invasive procedure called a fasciotomy, which is performed in an operating room. Most circumferential burns resolve beautifully with just an escharotomy. Finally, we reach Section 5, Specialized Burns and TAR. Let's look at how specialized areas of the body demand meticulous, customized care to preserve a patient's quality of life. The clinical protocols emphasize that treating areas like the face, hands, and feet comes with immense aesthetic and functional challenges. Because the face has such a rich blood supply and really loose tissue, the swelling is incredibly rapid and dramatic. Doctors are in an absolute race to check the corneas using a special fluorescein dye before the eyelids swell completely shut, which they can do for several days. Elevating the head 30 to 45 degrees is a really simple but absolutely critical maneuver to help drain that fluid away and protect the airway. Treatment adapts wildly depending on the anatomy too. For instance, to save an ear, you absolutely cannot use pillows. Even that mild pressure of resting on a pillow can cause the delicate cartilage to die. Mind-blowing, right? To save the function of a hand, you must elevate it and force active motion every single hour to fight off the swelling that could permanently freeze the joints. And for full-thickness burns to the genitals, the extreme swelling completely necessitates a Foley catheter just to keep the urethra open. In a surprising twist, roofing tar and asphalt themselves actually aren't toxic or chemically dangerous to the tissue. But because roofing asphalt is stored at temperatures up to 450 degrees Fahrenheit and applied at scorching temperatures, they cause devastatingly deep thermal injuries. The immediate medical priority is absolutely not peeling the hot tar off. That will literally just rip the skin away. The priority is aggressively cooling the molten material with cold water until it's completely hardened. The tar is then slowly and safely dissolved over time using a petroleum-based ointment.
So, I want to leave you with this question. When managing a burn, are we really just treating the skin, or are we racing against a cascade of whole-body trauma? As we've seen, managing a thermal injury is a high-stakes, systemic puzzle that proves the skin is truly our most vital armor. A burn doesn't just damage the surface, it tricks the body into leaking its own life-sustaining fluids, threatening shock, starvation of healthy tissues, and structural constriction. By understanding those invisible zones of injury, the catastrophic fluid shifts, and the precise timing required for surgical interventions, medical teams wage a masterclass battle against time. The next time you think of a burn, remember the immense physiological cascade happening beneath the surface and the incredible science required to stop it. Keep exploring, stay curious, and we'll catch you on the next explainer.